Thank you, Shubhashita, and thank you, OSWB, for giving me this opportunity. So I'll be, over the next few slides, we'll be talking on technological advancements which are helping us to navigate with very high myopic cataracts. So I have no financial interest to disclose. So these are some of the issues which should be taken care of while we are taking up a high myopic case. Like number one is biometry, number two is lens choice, number three is anesthesia, then capsulorhexis centration, and dealing with LIDRS, that is lens iris diaphragm retropulsion syndrome. So with the advent of optical biometry, ocular measurements are now very simple, quick, and more precise. And this is ideal in cases with extremes of axial length. Why so? Because in myopic cataracts, if we do an ultrasound biometry, you are picking up the data, maybe you are not picking up from the fovea, you might be picking up from a staphyloma and end up in a refractive surprise. And these are the newer generation formulas, which is another technological advancement in which we can see that Barrett and Olsen formulas are fairly accurate in all ranges of axial length starting from 21 millimeter to 28 millimeter. So these are the two lines which are almost within 0 to minus point and plus 0.25. So those are the most accurate formulas and precise formulas for high myopic cataracts. Now regarding choice of IOL, myopics usually have a very good near vision. When we remove the lens and make them emmetropic, they have some amount of difficulty for near. So the target refraction for distance should be minus 1 to 1.5, especially if there is a macular pathology. And the IOL material should be such that it induces the least amount of PCO. And it's better to avoid trifocal lenses in axial lengths more than 30 mm. Topical anesthesia is preferable for obvious reasons because while doing peribral anesthesia, we can puncture the globe, leading to catastrophic complications. Capsulorhexis size should be adequate. It should overlap the optic, not very big, in which the IOL pops anteriorly, leading to more myopic shift or PCO formation, and should not be very small, leading to capsular phimosis. It should be perfectly centered, and if not, then there are chances of PCO formation. Flax may be helpful. Now coming to LIDRS, high myopic eyes tend to have deep anterior chambers, often accompanied by weak zonules, thin posterior capsules, and a partially liquefied vitreous. So you should lower the phacoperimeter to avoid fluctuations in the posterior capsule. A second instrument can be put in place to prevent contact between iris, lens, capsule. So with newer machines, we can, with active fluidics, this again becomes a cakewalk. Like see in older generation machines, when we used to enter the anterior chamber, the whole lens iris diaphragm used to go back, deepening the anterior chamber, and see the iris plane is hardly visible. So this is LIDRS. It can be overcome with a second blunt instrument. Just lift up the iris and the pressure between the anterior chamber and posterior chamber becomes equal, and the LIDRS thing breaks. So while taking out the phacoprobe, do not forget to inject viscoelastic in the anterior chamber. Otherwise, it might lead to severe catastrophic complications. It might lead to retinal traction and tear. So again, in this particular case, you see with a newer machine, when we are entering the anterior chamber, look at my IOP at 30, it's 25 to 30 mm, it hardly causes any change in depth. So this is another thing which is very helpful, which has helped us a lot to operate these high myopic cataracts. Look, there is no change at all. Thank you very much.
That was very insightful, Dr. Ayan Mohanto. Before I go to the panelists, I would like to ask you a question. See, in biometry, you have impressed us that it is required to do a scan before deciding, because they might have. Now, when do you actually go for this A scan? Which level of myopia? When do you start?
A scan or B scan?
B scan, sorry.
Yeah.
A scan we are doing for biometry, so you follow.
If you don't have an optical biometer and you are having fluctuating values with your ultrasound biometry, you should go for ultrasound biometry. You should go for USG and find out if there is any retinal changes that is leading to these erroneous results. So in optical biometry is fairly accurate. I mean, you can get a fairly accurate value all across.
And do you always target -1 or 1.5 for
No,
all types of myopia, or is it
with,
higher?
with macular pathologies.
Okay, only with
Yeah.
macular pathologies, not for high
Otherwise,
myopia.
minus 0.5 to 0.75 is fair enough.
So it's near emmetropia.
Yeah.
Because we sometimes know that, as you said, there's a myopic shift. So do you target?
Myopic shift in case of if your capsular axis size is bigger, then the lens tends to pop out of the bag and
If there is a very
induces
deep
yeah.
EC, very deep AC.
Your axis size, because another important thing is doing a rexis is sometimes difficult.
Yes.
Because the chamber depends, you think that you are doing a small rexis, ultimately it ends up
Comes
with a
out
bigger
big,
rexis.
yes. So that is taken
It's
care
because
of.
of the
So you always
magnification
have-
factor
yes.
of the cornea.
Let us take some discussions from our panelists also. Ma'am, you would like to discuss this topic? Add your inputs on this?
Yeah, I don't do cataract surgery. I am only talking to the patients before cataract surgery. So a couple of concerns that whenever I have a high myo patient and somebody has done cataract surgery, the patient comes back very unhappy because they have not been told that now their life will change. They were using without glasses for near, things were magnified, and now they've been given distant vision very good, but for near they have to use glasses, and this was not explained to them. It could have been different. There could have been a different way of putting the IOL. But discussing with the patient is very important about their work and whether you're going to correct them for near or you're going to correct them from distance. That's very, very critical. Second, the type of myopia. Again, because I deal with a lot of children, so we have lenticular myopias, especially in ROP. It is not a axial myopia. Sometimes they have mixed myopia. It may be just index myopia. And of course, if it is an axial myopia, especially in children, then Stickler syndrome, have to be very sure that this is not a case of Stickler syndrome, because there the whole ballgame is different. They need very proper evaluation, and in many of those cases I do a lensectomy with intraocular laser and vitrectomy rather than putting an IOL, and then they really get very bad detachments. So I think some of the consideration, again going back to the history and the diagnosis, myopia is not one diagnosis, it's many diagnoses, and especially if you're going to correct one eye and the other eye, because we do RD surgeries, then they get cataract in that eye, the other eye has no cataract. Now what are you going to do? They are having -10 in one eye, and now they'll have +0.5 or -0.5 in the other eye. So I think these are difficult situations where, is he going to be monocular, is he going to use contact lens? And cataracts and myopia, again, other group is the syndromes. Myopia, cataracts are a part of many syndromes, whether it's Down syndrome or it is, our coloboma eyes. So in those cases, what type of surgery has to be done? Has it to be a lensectomy with vitrectomy, or it has to be a surgery for IOL? And what are you going to do with the PC? Because if they get a PC, then you're very always concerned about doing a YAG. So what type of treatment you're going to do for that? I think these are some of my concerns when I'm advising myopia cataract surgery.
Ma'am, since you talked about the retinal part, when would you advise a cataract surgery if you have done a retinal laser or retinal procedure after that?
So there are two groups of patients. One where vitrectomy has already been done, silicone oil removal or gas removal has been done. These are already vitrectomized eyes. We are fine. The surgeon should know that the AC will become, deep, and it will be. There may be a zonular dialysis or there may be a PC break already there. So in those cases, they can go ahead and do cataract surgery after 1 month of the retina surgery. Okay. There's no issue, but the surgeon has to be experienced in knowing that there are challenges when they do the cataract surgery. If we do laser for the prophylactic laser before surgery, so these patients usually, we say 1 month, but the 2 weeks is also fine because the laser is expected to finish their job by 2 weeks. But to be on the safer side, usually we say after a month.
Okay. Thank you. We have
And
high
then
volume.
Post-op, of course, the post-op care that they need periodical examination, whether it's a refractive surgery or cataract surgery. They need periodical retina examination, and that should be labeled in your file. Because what happens many times, they have already had cataract surgery done, but nobody is recording that this is a high myopic eye. Same for glaucoma, refractive surgery. So that in your file, that this is a high myopia patient who is now emetro because of cataract, that they need lifetime of retina checkup, not only for lattice but also for CNVMs and other things. Glaucoma, they can get
We have a
normal tension glaucoma, very common.
Two things are very important during the surgery. First is that AC becomes very, very deep. Even with the active fluidics nowadays, you have an IOP of 20. Sometimes the 20 itself is very high, and there is no way you can reduce it. So that's we are all doing now under topical the patient feels the pain, very too much of pain. And that is one issue, and regular, the iris becoming, shallow, small, and bellowing of the iris, this becomes a problem. So you have to come out and put viscoelastic and then do again. And the more the time you go introduce your Veco, the more the pain, patients will feel the pain. That is a real issue.
That's right. That's where IOP ramp, I think something called IOP ramp comes in, 2 seconds, 3 seconds we put. Anyway, Dr. Arup Bhomik.
Arup Bhomik, yes.
You've got some,
High volume.
you're a high volume
Cataract surgeon.
tackling a lot of myopic cases. Your inputs,
Arup, come in front, come to this one.
this one is working.
This is working. So luckily, madam said all the difficult cataract surgery in the myopia, childhood myopia, having retinal detachment. Lucky enough that our retinal surgeon do a lot of cataract surgery, and so in our case, myopic patient, we advise if you have a bilateral cataract, even one eye advanced cataract, one eye very less cataract, we advise them to try to consider the cataract surgery consecutively both eyes, so that they will face the less problem, because the anisometropia in between the surgery is a very disturbing. So if you one eye has a -6 and you correct it and you make a 0.75 in other eye, so it is very difficult to adjust this sense. Then we will tell the patient, you may delay it for 3 months surgery, but whenever you decide your surgery, try to decide your surgery very quick both eyes. This is the one tip. And another, that's surgical part which is very common. Trying to do a rexis, always you end up with a larger rexis in the myopic patient, because we have an impression to see the limbus or pupil as a guideline to do a rexis. So please look at the Parking's image and do the 2.5 or 2 millimeter Arundel package image, and this is the one tips I can give you. Thank you.
Great. That is why you use the, capsular marker, maybe.
Yeah, you
Anyway,
may use it.
thank